Good afternoon, my name is Christian, and today in this video lecture I'm going to be talking about perfusion and pulmonary blood flow. This content was pretty detailed, but what I managed to do was make it sound as simple as I could, and understanding this content helped me understand other chapters that were discussed earlier in the semester, and basically what this chapter or this content was about is basically how the right side of the heart works and pumping out pulmonary blood flow. So without further ado, let's begin. So we got a few objectives that we're going to be talking about. We got 4 of them here, which is the first one is how is hypoxic pulmonary vasoconstriction, or HPV, diminished in certain respiratory diseases. So we're going to look at some as to how some acute lung injuries affect this response, and I'll talk about that more. And I'll just go ahead and read the rest of them here. They explain how inhaled vasodilators can have beneficial physiological changes not possible through the systemic administration routes. Describe how mechanical and physiological changes can convert blood flow zones in the lung to different zone areas. That one's pretty fun to listen to, so check that out. And we're going to be discussing that too, and then this one kind of corresponds to the next and final objective, which is explain why the match between blood flow and ventilation in an upright lung individual is different in the lung bases than in the lung apices. So we're going to be talking about how pulmonary blood flow determines certain lung zones and how they change up. So without further ado, let's begin. So how do we define perfusion? The way I see it is basically perfusion in any sort of concept is basically fluid that's entering a specific part or a specific site of some sort of structure. In this case, this is about the movement of blood to a specific organ or tissue. And so basically perfusion on the right side of the heart, which is considered pulmonary blood flow, that pulmonary circulation is a low pressure, low resistance system in our body. So this is pulmonary blood out of the right side of the heart, and it's pumping upstream into our lungs to get oxygenated, and then do gas exchange and whatnot, get carbon dioxide out and oxygen in, and then moving that blood then becomes oxygenated and then goes back into the pulmonary veins to enter the left side of the heart, which is now oxygenated. So it enters the left atrial pressure into the left ventricle, and then out to our legs and our extremities and our head, giving us oxygen-rich blood throughout her whole body. But the pulmonary blood is pulsatile, while systemic blood flow is more continuous. So basically on each beat, like, pulmonary blood flow is kind of working its way to the lungs, and on its way there it's going to try to reach the left side of the heart, which is continuously giving out blood throughout her whole body. And the way I see it, the way I could define pulmonary blood flow circulation is basically through the heart, is basically you have to ride it. Check this out. You have to ride a bicycle. You have to ride a tricycle in order to ride a bicycle. It's kind of like how you gotta walk before you can crawl, or you gotta crawl before you walk. Excuse me. But that's how I look at it. The reason why I said you have to ride a tricycle before you ride a bicycle is because venous blood is coming out of the inferior and superior vena cavas, and entering the left atrium. The right atrium. It's entering the right atrium, and it has to go through the tricuspid valve, which then enters into the left ventricle. The left ventricle then pumps that venous blood throughout the pulmonary artery and into the capillaries that are surrounding the alveoli to then induce gas exchange. After that's happened, it becomes oxygenated rich blood, arterial blood, and then that starts coming through back into the pulmonary veins and back into the left side of the heart. in the left atrium. Once it enters there, it has to go through the bicuspid valve, bi meaning two, into the left ventricle to be pumped out through the aorta, and the aorta then sends the blood throughout the body and extremities and whatnot. So that's circulation in a nutshell. But that's a good way to look at it. You have to ride a tricycle before you're riding a bicycle. Tricuspid valve, bicuspid valve, meaning two. All right. So this relates to the first objective. So I kind of shortened it up a bit. The first objective was basically asking how is like hypoxic pulmonary vasoconstriction lost? How is it diminished? And to talk about what HPV is, hypoxic pulmonary vasoconstriction, basically it's a normal response in the body when there's an increase in PVR, or there is a lot of carbon dioxide being built up, which is also whatever is increasing PVR, which is our pulmonary vascular resistance, that could then back up blood from entering certain parts of the lungs in different zones. So that's when it's activated. This response then comes out during hypoxic environment. So like if you're in high altitude areas, you're running for breath, you're trying to get oxygen ventilated throughout your body, and what happens is basically your heart is pumping faster, so the PVR, which your right side of the heart, is trying to pump more blood to the lungs a lot quicker, more venous blood to the lungs a lot quicker, and it's trying to do that, but it's not getting as much. Though you're still getting like some oxygenation, you're only getting partial. So let's say like the pulmonary, like the heart has 5 liters of cardiac output coming out, 5 liters a minute, which is the normal cardiac output for the heart. Going around circles, it's the same. Same for both sides with the systemic. But in order for the body to become oxygenated, that deoxygenated blood needs to enter the lungs to get oxygenated. So what happens is, let's say one of the pulmonary arteries is cut off to the left lung, but the right lung is good. Vasoconstriction will then occur to move like the venous blood from poorly ventilated areas, that left lung, the one that's jacked up, it's going to move blood to better ventilated areas of the lungs. So that's going to move it to the right lung because it's more ventilated. It's a lot better. So that's how it works, and that's what the response does in during hypoxic pulmonary vasoconstriction. It's basically diverting mixed venous blood to better ventilated areas of the alveoli in that lung, in the better lung, pretty much. So it's going to look like, in a way, it's like a shunt, but rather it's more looked at like a normal response, normal body response. And like I said, well, I just say here that it could be reduced by giving supplemental oxygen to someone. So like say they come down, they're having altitude sickness. They're coming down from the person that just climbed the big hill, who was hypoxic, now went down the hill, but he still can't breathe. We got to give him some supplemental oxygen to recruit the alveoli and get him back to breathing normally again. I also want to say that when this process has to happen with a P big AO2 that's less than 70 millimeters of mercury, or like I said again, when there's high amounts of carbon dioxide in the body, the lungs are now receiving. It's very acidic in those. It's becoming very acidic in the heart, and the pH, or in the lungs, and the pH is dropping, and basically we're trying to add more base to the lungs, making the lung zones and the breathing a lot more alkalotic. So so knowing that that's a normal response, kind of like it's a good thing, but also a bad thing. We're gonna see how HPV is kind of diminished, like how it's gone. And how that happens, it's like if there's no moving of like the PVR, that's just going to keep building up. PVR is like it's going to stay increase. It's not going to know where to go. So why is because it's diminished when it's diminished in the body. It's because in acute lung injuries, and we'll talk about those right now. Uh, basically, yeah, nitrous oxide synthase is synthesizing in the body, which is it basically releases out of the lungs, and it's kind of helping vasodilate in a way during acute lung injuries. So this is when HPV is lost or diminished, and it can happen with several things. A few of them will be like burn patients, patients or people that have acute respiratory distress syndrome, which is known as ARDS. Burn patients, again, smoke inhalation patients. Just ignore that one. But basically, anyone that has gone through any sort of like out of a fire, they have all this smoke inhaled and carbon monoxide buildup, so that's not good. Or basically, so what happens in those sort of conditions is alveoli recruitment is down, and so normal vasoconstriction response, which was HPV, is now inhibited. It's stopped because the body is kind of doing its own thing and to kind of make things better, but reality it's not. So when that happens, also like so that's pretty much that in a nutshell. Any acute lung injuries is sort of when it's acute respiratory distress syndrome, burn patients or smoke inhalation patients, or even mechanical ventilated patients. It could inhibit the response, the normal response of hypoxic pulmonary vasoconstriction. So it's not going to be diverting blood. So basically what happens is poorly oxygenated blood, mixed venous blood, is going to go unchecked. It's going to flow unchecked and underventilated in regions of the lung, in certain underventilated regions of the lung. So like this blood flow is going to go in the wrong side. It's going to go under like the wrong sides of the alveoli. Basically, it's going to go unchecked, and it's like, oh, here's the alveoli, here's the blood, it's coming through. It's like kind of missed. It didn't do anything. It just missed, and that's going to create some severe shunting going on, and basically systemic hypoxemia. The left side of the heart is going to not be supplied with that rich oxygenated blood, and then it could just lead to heart failure, especially for the right side of the heart, which is known as cor pulmonale. Right, and everything just kind of goes wrong from there on in. So giving them supplemental oxygen, it won't cut it. It's not because it's not going to enter ventilated alveoli. There's pretty much like, I don't want to say an absolute shunt, but there's just the normal blood flow or perfusion of the blood of pulmonary blood is not doing its job by entering the alveoli. So how there's two other things that HPV is lost or inhibited is when there's mechanical ventilation. What that does, it can overinflate and overstretch the alveoli, which then could cause injury to it. This will induce nitrous oxide synthase to occur, kind of inhibiting that HPV response, or any damage to the alveolar capillary membrane would increase permeability, meaning fluid overflow. In my way of explaining it, it's kind of just like the alveoli just are damaged, and there's going to be a decrease in surfactant, which is going to cause fluid to come in, or like cause the alveoli to just shrink, and basically that's not good. It's going to collapse, and that could be done by these things that are happening here too, smoke inhalation patients, and that's pretty much not good, and HPV will just become inhibited. So with that said, let's go on. So the next objective that we're going to look at was basically how. So that was the first objective we just talked about. Here's the next objective. How do inhaled vasodilators how do they help? How do they help in a patient's pulmonary blood flow or a person's pulmonary blood flow? So what we give them basically is nitric oxide, inhaled nitric oxide, not, depending on the nitric oxide that can be made into the body. Giving them inhaled nitric oxide, which basically, so if they have, a patient has an increased PVR, it's backed up on the right side of the heart is backing up blood. It's, not giving out supplemental venous blood to the lung areas and whatnot. It's going, giving them inhaled nitric oxide will selectively vasodilate, and I'll talk about that, what that means in a second. It's going to ultimately pretty much just decrease PVR and improve VQ mismatching. So now there could be blood flow to entering underperfused alveoli. So that's basically generally going to help that. It kind of like goes in there and aids the HPV response or hypoxic pulmonary vasoconstriction. It's going to kind of just dilate the vessels in well ventilated lung regions, though. I think I said poorly ventilated. I meant to say that inhaled vasodilators only work for well ventilated lung regions. So it's gonna like move mixed venous blood to those areas, and kind of decreasing PVR, and that's what we want out of inhaled nitric oxide. So like I said, it selectively vasodilates. So by doing what I just described, and this can also treat hypertension as well. So it could like just pretty much inhibit any hypertension from happening, any buildup of carbon dioxide as well. So the one thing to know about is that we should not be giving this orally or intravenously, and the reason why is because it could worsen shunt and HPV. So it's basically just not going to allow the body to do its job when it's inhaling a vasodilator. So when it will, but then here's what's going to happen. So not only that the pulmonary blood pressure is going down, but also the systemic blood pressure is going down. So when nitric oxide gets into like the hemoglobin in the blood, what's going to happen is that's going to like I said, not only just worsen shunt and HPV, but it's going to cause some sort of inhibition to the vasodilator. Basically, it's going to stop nitric oxide from working. It's not going to help the lungs. It's going to help a little bit of the lungs, but mainly the body, and it's going to start dilating blood flow to our legs and our brain and everything, and that's going to lead to other things such as heart failure and respiratory failure. So we can't have that happen. We can't have this amount of blood coming through this vessel, and that's not good. So that's why it selectively vasodilates when we give it inhaled, and we should never give it intravenously. Okay. So let's move on. This will be our third objective, and so this is basically described as how do lung zones physiologically change. This is like the third objective we talked about. Kind of just an easier way to simplify that. So let's kind of see the lung zones. Lung zones there's 3 different ones in our lungs, and we should know that there's pulmonary blood flow kind of coming through these zones, but there's supplemental blood going to each one. So as you can see here, I like this picture because it says perfusion is absent, and for the first zone, that's because there's more, there's a higher pulmonary alveolar oxygen tension in that area than the arterial, or excuse me, yeah, the arterial blood. I said pulmonary, but this is like, it goes for both ways. Zone 2 is perfusion, is sporadic or intermittent flow, or it's just pulsatile. Basically, there's always blood flow coming in and out like a waterfall, which then leads into the Zone 3, which perfusion is constant. So how do they change? So like I said, just kind of a summary of what I just said. So in Zone 1, little to no perfusion. There's high resting volumes in that area. Meaning high resting volumes of the alveoli. So the alveoli are big, they're kind of huge in Zone 1. And the arterial is fairly small. So venous blood is not going to go in there as much. It's not going to be as great. Arterial and venous blood is not going to be as great as alveolar, or alveolar pressure, excuse me. Arterial and venous pressure is not going to be as great as alveolar pressure. Alveolar pressure is going to be big, and it's just going to kind of pinch that that capillary from receiving any blood flow. So there's more ventilation but less perfusion. And in Zone 2, it has normal perfusion and ventilation, so that's about like equal to 1. And like we said, it's basically just pulsatile blood flow that's always be coming in from that area and just kind of dipping down to the next zone. Which would be, it says vessels are always open and continuous blood flow and ventilation enter the alveoli due to gravity. Because of gravity, more blood flow will enter the bases of the lungs, and I'll explain that a lot more in this next slide coming up. So, basically, the next slide was going into something else, but in this slide, so we want to know how these lung zones change. How can 2 be 1, and how can 3 be Zone 3 be Zone 2? So how that works is, let's talk about how Zone 1 works. Zone 1 is not really created until there's like less perfusion and more ventilation happening. So let's say like if you're coughing, or doing some sort of Valsalva maneuver, or blowing through a trumpet, you're trying to apply that back pressure, positive pulmonary pressure, or positive pressure. Or like even when you're applying a lot of pressure, like when you're lifting weights, like you're kind of closing the glottis down, which will then lead to an increased PVR. But what happens in that situation is like some sort of Valsalva maneuver or any other maneuver, basically kind of capping out, kind of like moving out like less blood flow to that area. It's going to be mainly going around here. So Zone 1's created. There's a lot more ventilation in this area, like I mentioned, but less perfusion. So that's how we can create Zone 1. Ultimately, what can then happen is, cutting off like, that's gonna, it's gonna be more of a dead space effect in Zone 1. It's gonna be a lot more of an alveolar dead space. So it's usually created there in Zone 1. Zone 2 could turn into Zone 1 by mechanical ventilation. That's what I wanted to say. Basically, like I mentioned, it's going to cause an alveolar dead space. So in that zone, alveoli is not easily distended. So there's a lot of pressure being applied, which can create an alveolar dead space. And Zone 3, well, Zone 3 could be Zone 2 if there was like a pulmonary emboli. So like if there is like a blockage in the pulmonary artery, it's not going to be receiving a lot of blood. So it would just stay as Zone 2, kind of just in this area. And alveolar pressure in Zone 3 is a lot smaller than arterial and venous pressure, so we know that there's a lot more perfusion than ventilation. But when there's a pulmonary emboli is like blocking a lot of that blood flow coming out of the pulmonary artery, it's going to turn into Zone 2. So that's how we can have zones change like that. Also, All zones could be created and equally distributing blood if someone was just exercising, like if they're just running their normal cardiac output, meaning it's just going to go ahead and just give blood flow throughout all the zones. So they're kind of going to be equally, they're going to be they're going to have equally distributed lung volumes until the person stops and breathes, and then the zones are created again. So now that we talked about that, let's talk about the next slide. This one is how are blood volumes different in the apices and bases in the upright lung. So this is the last objective we're going to be looking at. Thank you for bearing with me. So here's, like, again, we have an upright lung. I wish I had a better picture, but this is the one I really like because it basically summarizes what I just talked about in the previous slide. So how zone 1 is with the pressures up there, and zone 2 is, and zone 3. But basically how we look at it is in an upright lung. You know, a person sitting upright. This is basically just a summary of what I just said. There's more ventilation in the alveoli because it has higher resting volumes. Alveolar will always be greater. Alveolar pressure is always P big AO2 will always be bigger than arterial, but pretty much over venous blood too in the capillary. So there would be a high VQ in that zone, in that zone 1. So, but what that means, high VQ, is there's more ventilation than perfusion. So like I mentioned, you know, there's big higher resting volumes. The alveoli is big, and then the capillary that's running by is like really, really tiny. So there's going to be like less perfusion up there. And this is in an upright lung. So what happens going down to zone 2? That's kind of just normal VQ. Normal blood flow is going down until it hits to the bases. I should have mentioned that this is the dead space effect again. So like I said, ventilation but no perfusion is dead space. So we're looking at zone 3 now. Due to gravity, blood flow is going to drop to the bases of the lung, and that's going to essentially cause more perfusion, but and actually 20 times more perfusion in the bases than ventilation. But I should note that there's always going to be ventilation throughout the lungs, but only generally like 4 times as more in the bases than in the apices. So it's still receiving ventilation, but not as much as perfusion. And this is going to be this is going to indicate a lower VQ, which we have here. So that means there's lower ventilation, but more perfusion. Ventilation mean V, and Q is perfusion. And so overall, the normal resting lung VQ ratio is about 0.8. Which means on average the ventilation is less than perfusion. That's what basically summarizes this objective. And of course, with exercise, VQ ratios change. Whatever you're doing to the body, there's always a change of VQ ratios. Lung zones will always change, which will increase or decrease. And that's pretty much about it on that one. So now we can go on to some test questions that I've formulated. So here we go. This is going to kind of summarize what we just learned and what I just said. So the first one is in acute lung injury, an increase in surface tension to the alveoli will likely cause them to improve in oxygenation, decrease capillary permeability, shrink or collapse, or decrease in shunt. Now let's look at this. This one's kind of like a critical thinking one because each one of these things do happen when there's acute lung injury and an increase in surface tension, which is already happening to the alveoli, but the increase in surface tension only pertains to one of these answers. All this is happening in acute lung injury, but A few of them are wrong, of course. 3 of them are wrong. 1 of them's right. So does it improve in oxygenation? You look at it this way. If you see a balloon, let's just say, or you see like, yeah, a lung, and it has all this oxygen, but some fat kid just sits on it, it's going to increase the surface tension. You think that's improving oxygenation? No. So there's going to be less oxygen entering the alveoli. Decreased capillary permeability? No, that's actually going to increase it. Like I said earlier in this lecture, acute lung injury can inhibit HPV, hypoxic pulmonary vasoconstriction, but it's going to actually increase capillary permeability, kind of like which is going to decrease your surfactant and cause more fluid entering the alveoli, which is not pretty much bad. So it's actually going to increase permeability. It's going to increase the bringing in of fluid into the alveoli and basically cause it to shrink and collapse, which I just said. The answer is right here. All these pertain to one thing, and it's that. So it's kind of a cool way I set that question up. And decrease in shunt? No, it's actually not going to decrease in shunt. Shunt's going to happen, so it's actually be increase in shunt, which is like an increase in your pulmonary artery pressure, which is PAP, and actually cause an increase in your PVR as well. So yeah, so the answer, yeah, is 3, shrink or collapse. Next text question we got is which lung zones compose the distribution of pulmonary blood flow? Select all that apply. So I got to select that all that apply question here. So like I said, we just talked about what lung zones are and how they work. So lung zones compose the distribution of blood flow. Which ones though? Of course, looking at these, it's kind of obvious. There's only 3. So there's zone 1, yes, because that's the zone and the apices of the lung. Zone 2, yes, because that's in the middle of the lung. That's like normal perfusion and ventilation occurring. Zone 3, yes, because those are the bases of the lung. There's ventilation, but there's a lot more perfusion going on. So yeah, you got dead space due to pressure changes. You got normal VQ going on around here in zone 2. Zone 3, a lot more perfusion due to gravity. Zone 4, what the heck is zone 4? Zone 4 is just there to throw you off, so there's no zone 4. If there was a zone 4, that would just be weird. I don't know what I would consider zone 4, my legs or my butt. So the answers are zone 1, 2, and 3. I didn't put letters, but yeah, zone 1, 2, and 3 would be your answers. Next test question I got. Mechanical ventilation can cause an increase in alveolar dead space. To which zone? So let's look at this question. It's kind of like, in a way, it's giving out a true statement, but it's also asking, like, it also wants us to finish that true statement. Mechanical ventilation can cause an increase in alveolar dead space. It can. To which zone, though? Is it going to be in zone 3, 2, 1, or none of the zones? We can rule out D because, of course, it's going to change the zone. It is. But we just got to know which one. Zone 3? Not necessarily. It will be receiving adequate ventilation, but it's not going to change the perfusion. It's still going to be like that. Like I said, that 20 times more perfusion than ventilation, or in the other lungs than in the other zones. It may drop it to like 15, but it's still going to be a lot. So zone 2, yes, but that's not. It's increasing in dead space, but it's not the biggest one. It's not really doing much. It's still being both ventilated and perfused normally. What it's going to be causing more of it, with the zone is actually going to be causing more of an alveolar dead space in zone 1, because like we mentioned, there's higher resting volumes in that zone, and essentially it's already big enough. Adding more pressure ventilation to that alveoli is just going to get, it's not going to even have more room to expand anymore because they're so big, and all the other alveoli are just going to be full of positive pressure ventilation, oxygen, pretty much filled up air, and it's just going to completely cut off perfusion to those, it can completely cut off perfusion going to those alveoli in the apices. So zone 1 is your answer, which because alveolar dead space is ventilation but no perfusion. And last would be our practice. The last practice text question we got here is pulmonary. It says pulmonary blood flow flowing continuously to the bases of the lung does what to the VQ ratio? So let's look at that again. Pulmonary blood flow flowing continuously to the bases of the lungs does what to the VQ ratio? Will it increase in VQ? More ventilation, less perfusion? Will it decrease in VQ? More perfusion, less ventilation? Or equal VQ units, or no change? Basically, this all looks like a bunch of jargon, but again, this thing is like a true statement. We just got to finish it. Pulmonary blood flow is flowing continuously to the bases, so the lungs, but to what does it do to the VQ ratio? Well, actually, I know this seems kind of rather confusing, but it doesn't really necessarily drop, but you would see a decrease in ventilation, but you'll see more perfusion. That's why I put those wordings there. So it's not going to increase in ventilation or VQ because that's more ventilation, less perfusion. That pertains to the apices of the lungs. Equal VQ units? No, not really. Because I'm talking about the bases. This is talking about like the middle of the lung. And no change, there's obviously going to be a change. Any amount, that's increasing blood flow to the bases will change the ventilation and perfusion ratio. So the answer is B. It will decrease in VQ. It will decrease in ventilation, but there will be more perfusion. So decrease in VQ, more perfusion, less ventilation. Okay, and basically these are the references that I've used for the discussion of this lecture. I just want to say thank you very much for taking the time to listen to this. And I didn't put it up there, but if you have any questions or comments to this PowerPoint or lecture, feel free to use the Hartnell base and look for, or Hartnell email base and look for Christian Galvin, or you can find me on my normal emails. My primary email is actually Christian Galvin, my first and last name, 555@gmail.com. That's Christian Galvin 555@gmail.com. And thank you very much. Have a good day.